rheumatology, as we treat arthritic conditions, we are very fond of destroying a lot of organs in the human body. The liver is one of them, so we have to always deal with hepatologists to repair what we are messing. The stomach also, we are about the stomach. We're constantly destroying the stomach with our medications, and the gastroenterologist is always, we have to communicate with him to repair the stomach. So we always have to maintain a very good relationship with our colleagues, the gastroenterologists. And there are certain diseases where we and the gastroenterologist, we work together hand in hand in the management of patients. And one of those very important diseases are the inflammatory bowel diseases. I thank Dr. Sarat for letting me have this opportunity to talk. Actually, I'm the one who pursued this. I communicated with him and I requested to give that talk to clarify some issues about the management of IBD from the perspective of a rheumatologist, and to also mention the word biologics a lot, because this is the issue that we have with our colleagues, the gastroenterologists in the management. The entire spectrum of GI disorders where arthritis is a recognized extraintestinal manifestation encompasses the list. Inflammatory bowel disease, bacterial infections, celiac disease, Whipple's disease, others, but IBD is the most important. Ulcerative colitis and Crohn's disease are the most frequently encountered GI disorders that are associated with musculoskeletal manifestations, namely arthritis or spondylitis. The IBD belongs to a family of called the spondyloarthritis. The spondyloarthritis family is characterized by three main features: inflammation around the entheses. The entheses are the very insertions of the ligaments or tendons into the bone. B27 association and a group of clinical features like inflammatory back pain, peripheral arthritis, bowel disease, dactylitis, uveitis. The topics of this talk are the prevalence of the arthritic involvement in IBD, the predictors, how it looks like, lab findings, diagnosis, and management. So, how prevalent are the musculoskeletal features in IBD? They are prevalent enough. Like 10 to 13% of patients will have musculoskeletal manifestations, whether this is a peripheral arthritis or a sacroiliitis. The other way around, the prevalence of IBD in patients with spondyloarthritis. When we diagnose a patient with spondyloarthritis, it's not always a clear diagnosis. It doesn't have to be ankylosing spondylitis in particular, psoriatic arthritis. Sometimes it's an undifferentiated spot, undifferentiated spondyloarthritis. Whether it is this or that or a clear disease, we know that subclinical gut inflammation is present in around 2/3 of patients with spondyloarthropathies. The predictors of arthritic involvement: number one, large bowel disease. So even if you have Crohn's disease, if you have large bowel affection, you are more likely to get arthritis. The other one is extraenteric features. If IBD chooses to go for extraenteric features, we are one of those features, in addition to the erythema nodosum, stomatitis, uveitis, and pyoderma gangrenosum. By the way, pyoderma gangrenosum, if we see a patient with arthritis, especially if it's in the lower limbs, and they have the healing scar of a pyoderma gangrenosum, always IBD is in the differential diagnosis, in addition, of course, to like Behçet's disease, for example. Age and sex factors: adults and children, males and females are equally affected. The arthritic involvement. The arthritic involvement can be an immune-mediated. Typically, if we speak of IBD with arthritis, we are mostly thinking of the autoimmune arthritic element. This is the most common, of course, this is the most prevalent. But there are other also features like infectious arthritis, a part of an erythema nodosum, HPO, or an adverse effect of treatment for IBD like steroids. So the immune affection, it could be an axial involvement. Here, the axial involvement is sacroiliitis or spondylitis. Clinically, the typical is inflammatory back pain that is more in the morning and at night, and it decreases and walks off as you move around. But I chose this picture. We call this tandem sciatica, which is very common, very peculiar, and very discriminating. Tandem sciatica means that the patient will come with a sciatica on the right side today, and after 1 or 2 weeks or 3 or 1 month, he will come with sciatica on the other side. This tandem sciatica is very أنا عايز نبين هنا بس عايز انقل السلايد بس خلاص أنا بستعمل. So the axial involvement is inflammatory back pain, and tandem sciatica is very discriminating and from the common mechanical back pains. Peripheral joint involvement or peripheral affection, this could be an arthritis joints. Typically it's a lower limb oligoarticular arthritis. Oligo is 4 or less. One joint is monoarthritis, 2, 3, 4, this is oligoarthritis. Typically it's the knees and ankles, and it doesn't have to be symmetrical, mostly it's asymmetrical. But it can be an RA-like affection with an MCP, metacarpopharyngeal predominance. Also there's involvement of the enthesis, like this picture of an Achilles tendonitis, and dactylitis, which is inflammation of the tendon and all the soft tissues of a finger or a toe. And it can be both, it can be a combination of both. So this is the immune-mediated, which is the most prevalent, the most important. Infectious and arthritis can be also an option, can be a possibility, especially if a patient presents with a monoarthritis. If a patient with IBD presents with a monoarthritis, it could be an immune-mediated arthritis, of course, but we have to exclude an aseptic arthritis, especially if it is a mono, or sometimes if it's an oligoarthritis. A new onset monoarthritis as an IBD patient should be considered septic until proved otherwise, probably mostly in enamel aspiration, enamel synovial fluid cultures. It's common especially in fistulizing Crohn's disease, and patients, if they're immunosuppressed with the treatment of the IBD, so septic arthritis is a possibility that we have to be really aware of if it's a mono or oligoarthritis. And the organisms are not always, don't have to be bacterial, sometimes mycobacterial and fungal, with a slightly faster, and this explains the oligoarticular involvement sometimes. Erythema nodosum and HPO. Erythema nodosum, it's mostly a skin presentation. The subcutaneous painful, tender, red nodules, but sometimes the erythema nodosum itself has an arthritic element, like the idiopathic EN has arthritis as part of the EN, but the point is that sometimes the red nodule is in a very articular location, so you don't know if this is an erythema nodosum or this is an arthritic red hot swollen joint. And the other thing is the HPO, especially in Crohn's disease. It's not about clubbing only, it's also about arthritis. And the last one, an adverse effect of treatment. You initiate steroids for IBD, and this can be complicated by osteonecrosis when the blood flow to the head of the neck of the femur, for example, is cut off, and then you get deformation of the head over the time. Lab findings, we don't have specific lab findings, they're mostly non-specific lab findings that reflect an acute phase response, elevated ESR and CRP. B27 is present in only 50 to 70% of patients. We do not rely on it. For us, if we are seeing a patient with arthritis and he has a disproportionate or an unexplained iron deficiency anemia, like if I see a patient with oligoarticular arthritis and his hemoglobin is like 7 and his MCV is like 65, 68, if I exclude an NSAID-induced problem and a thalassemia trait, which is not uncommon, IBD is always in the back of our minds. Radiographic findings, on the left side, this is a normal one. Here on the right side, this is a sacroiliitis. It's not always so easy to pick sacroiliitis because the sacroiliac joint has different planes, and even we rheumatologists, sometimes we have debates about what is positive and what is negative here, and we mostly rely on MRI, which is where the findings are really clear. Like here in this, on the right side, this is a T2 weighted image. The bright color, this is water, this is osteitis, this is bone marrow edema, and this is a typical sacroiliitis. Diagnosis. In a gastroenterology clinic, if you have a patient with IBD and he develops joint pain and stiffness or symptoms of inflammatory back pain, you probably need to communicate with the rheumatologist. He will have a general history and physical examination. If the joints, if there are peripheral joints affected, so he will look for the tenderness, the swelling. We do some lab tests that reflect the acute phase response, and we will exclude potential causes of similar symptoms like Behçet's disease, celiac disease, reactive arthritis. An important note here also, there's another setting. If you have a patient with IBD and he develops a monoarthritis, it's important to know that in addition to the fact that it could be an immune-mediated arthritis, as we just mentioned, it could be septic arthritis, and this is a medical emergency. It's very important. You can lose the joint in only 2 weeks. So it is important in such a setting to refer to a rheumatologist who will perform a joint aspiration to exclude the septic arthritis. Now, the other way around, how about us rheumatologists? In a rheumatology clinic, a patient with IBD will be suspected. If a patient with spondyloarthritis develops abdominal pain, diarrhea, or weight loss, or manifests with an unexplained anemia, I need to refer him to the gastroenterologist for one of two possibilities. Either IBD or GI blood loss secondary to our medications, the NSAID especially. Now, management is just the same for IBD, for us rheumatologists. It's just the same for us, the same broad lines like we use in the treatment of the other spondyloarthritis family members. We mostly see in the spondyloarthritis ankylosing spondylitis and psoriatic arthritis. Those are the most common. We see less commonly IBD, us and other rheumatologists everywhere. So the broad lines, we derive them from our experience with the other members of this family and from expert opinions about the optimal management of musculoskeletal manifestations in IBD patients. Sometimes the management is complicated by the need to coordinate with the gastroenterologist about what works best for both of us, the joints and the GI. The peripheral arthritis, this is the broad line. Initially we start with NSAIDs, sometimes local steroids. If it fails, we go for disease-modifying drugs that are not biologics, mostly sulfasalazine. If it doesn't work, we go for a biologic, and we'll be very happy if also the patient needs the biologic for the GI disease, for example, or an axial arthritis, in addition to the peripheral one that we're dealing with right now. And if this fails, we go for a second line biologic. Concerning the NSAID, how safe are they to prescribe in patients with IBD? In the literature, of course, it's mentioned that NSAIDs can initiate or can exacerbate the IBD disease. There are no clear studies that really study this relationship. The experience is that they are safe enough. Which NSAID to prescribe? We prescribe either the non-selective or the selective COX-2 inhibitors. We are very fond of naproxen, not because of a specific issue with the IBD. It's a general preference for the naproxen because it's one of the least troublesome when it comes to side effects. We prescribe at anti-inflammatory doses. What if the prescribed NSAID fails? We might try another one. Why I mention might? Because sometimes the issue is a contraindication or a problem with the NSAID as a family. In that case, we will leave the NSAID family. But if one didn't work, that it did not improve the patient in 2 to 4 weeks, or it was not tolerated by the patient, those are the definitions of failure, we go for another NSAID. But we don't go for a third. We try only a second NSAID after that. And of course, we never combine two NSAIDs together. Concerning the non-biologic, sulfasalazine is still the number one possibly used in patients with peripheral arthritis, plus or minus a bridge of glucocorticoids until the sulfasalazine will kick in and will start to work. Of course, there are options other than sulfasalazine, azathioprine, methotrexate. Mesasalazine doesn't work for us because what we get from the sulfasalazine is the sulfapyridine component. This is what works in our joints. And you take the 5-aminosalicylic acid component for the colon. Methacillazine doesn't have a component that would work on the joints, so it's not suitable for a patient with a peripheral arthritis. Concerning the biologic, anti-TNFs is the family that we use. Of course, not all the anti-TNFs are applicable here. It's most of them actually, but etanercept is not working for the IBD. We go for the infliximab, adalimumab. Mostly those are the two more commonly prescribed. Coordination is very important between the gastroenterologist and the rheumatologist, because what works for the joints doesn't always work for the GI, like etanercept, it works for the joints, it doesn't work for the GI. And what works for the GI sometimes doesn't work for us, like there's an we're not aware of that even, it's not in our literature. Vedolizumab. It doesn't work for the joints, it works only for the GI. So it has to be well coordinated between the rheumatologist and the gastroenterologist to know what's best for the patient. Presence of active infection is an absolute contraindication, especially fistulizing Crohn's disease. In our literature, this is a clear contraindication. Rheumatologists and gastroenterologists seem to have different attitudes to prescription of biologics, which is one of the main reasons why I wanted to come to talk here. My colleagues, the gastroenterologists, they are very apprehensive about prescribing biologics, and we've been prescribing them for a long time. Like me and my colleagues, we published this back in 2009, which is almost 10 years now, and by that time, we had enough patients on biologics to describe 3 years experience with the prescription of anti-TNFs. My colleagues here in this article, one of them is Mustafa. Mustafa is a gastroenterologist. The collaboration here is that he was referring to me the patients and I was the one prescribing the biologics, even in patients who were not having any arthritic components at that time. But now he's an aggressive prescriber now to biologics. So this is the management of peripheral arthritis. Spondylitis is just the same, except that the non-biologic DMARDs do not work here. Sulfasalazine, methotrexate, azathioprine, they do not work for the axial. So if you miss the NSAID station in the axial spine, you go straight to the biological agent station. In physiitis and dactylitis, it's more or less NSAIDs, or you have to go for a TNF inhibitor. The prognosis, the long-term outcome of patients is commonly defined and dictated by the IBD, by the GI component. Our arthritis is not that aggressive and not that debilitating in patients with IBD. So the final say is always for the GI involvement. So to conclude, IBD-related musculoskeletal presentations, it is actually a constellation of different entities. It could be the immune-mediated, which is the common that we all know. It could be aseptic arthritis. This is very important to put in mind, especially if the patient presents with a monoarthritis or an oligoarthritis, especially if the patient is on immunosuppressors also. It could be part of an Erythema nodosum or hyper-HPO, or it could be a complication of treatment like steroids, and this is a monoarthritis, mostly of a hip or a shoulder or ankle. Management of IBD with arthritis is done in collaboration between the gastroenterologist and the rheumatologist. The long-term patient outcomes are commonly defined more by the course of the IBD rather than the arthritis. Thank you so much.